Thank you, and I just want to first of all thank the organisers for including me in this very important initiative, and just also thank you our task group members, Sophia, Stephanie and Alize, for an enjoyable process together. So in terms of germline pathogenic variants, they're going to account for anywhere between 6 to 17% of contemporary breast cancer cohorts. And it's going to really depend on who we're looking at when we make this assessment. What's the age of the cohort, the subtype, so in triple negative we'll find more BRCA1 or 2, what stage of disease, and of course ethnicity. And BRCA1 and BRCA2 are the most common pathogenic variants amongst women with breast cancer. Why do hereditary predisposition genes predispose to cancer? Well, BRCA1 and BRCA2 code for proteins that are important in the DNA repair pathway, particularly for repair of double-stranded DNA repair breaks. We can also see that there are other pathogenic variants that we're familiar with that are associated with hereditary breast cancer syndromes on these pathways. So we can see the CHEK2, the ATM, the PALB2, and they're on these shared pathways. And we can understand from this why PARP inhibitors might be advantageous. We know that BRCA deficient cells are sensitive to interventions that are going to cause or promote double-stranded DNA breaks. So this could include radiation therapy and, of course, chemotherapy, particularly platinum-based therapies. And we also know that the BRCA1 or 2 deficient cells are going to be more sensitive to PARP inhibitors because the PARP inhibitors diverge the repair of single-strand break towards the homologous repair pathway, which is deficient in the BRCA1 and 2 deficient cells. At the moment, we have 2 PARP inhibitors that are FDA and EMA approved for the use in breast cancer. We have olaparib that is approved in the advanced and early breast cancer setting, and we have talazoparib that's approved in the advanced breast cancer setting. So in early breast cancer, the registration study was the Olympia study. This was a phase 3 study that randomized patients who had a germline BRCA1 or BRCA2 mutation, who had high-risk features. So this included women who had either residual disease after triple-negative breast cancer, or they had significant residual disease after neoadjuvant treatment for hormone receptor-positive breast cancer, or for those who underwent upfront surgery, they had high-risk disease to begin with. These patients completed their standard of care treatment. And once they were after completing their radiotherapy several weeks out, they were randomized to receive either olaparib or placebo. What we can see is that we're dealing with a younger group of women, as we might expect when we're looking at a group of patients that have germline BRCA pathogenic variants. The median age was around about 42. Many of the women had undergone mastectomy, but keep in mind that most of these women would have had to have received radiotherapy to participate in this study. All the patients had received either neoadjuvant or adjuvant chemotherapy, and anyone who was hormone positive also received concurrent endocrine therapy. The study reached its primary endpoint with an improvement in invasive disease-free survival with an overall benefit of nearly 9%, favouring the olaparib arm. When looking at the overall survival benefit, there was a benefit of nearly 3.5% favouring the olaparib arm, and this is only at the 4-year follow-up, and so we'll have further follow-up to see what happens with time. I will remind people that the hormone-positive subgroup was actually added quite late into the study, so we're really going to have to follow up further to see the added benefits. And I haven't shown the slide here, but when it comes to distant disease-free survival, the reduction there was just under 8%. In terms of adverse events, so we can see that the key adverse events with olaparib, what we know already from the metastatic setting: nausea, fatigue, and some hematological toxicities. And what we might want to note when we're thinking about radiation and the interaction with radiation was that pneumonitis was marked as an adverse event of special interest in this study, and that the pneumonitis rate was no different between the 2 arms of the study. Another interesting study, and it's an interesting study because it's the basis now of many other ongoing studies, was the NeoTALA study that was led by Jennifer Litton. And this was a pretty brave study where they gave just single-agent talazoparib in a group of women who had BRCA1 or BRCA2 germline pathogenic variants in the neoadjuvant setting. And they had a pathologic complete rate of 53%, which is quite remarkable. And so there are several ongoing studies now looking at the use of PARP inhibitors in the neoadjuvant setting, some with immunotherapy, others without. An important study presented at San Antonio was the JEPAR-OLA study. There is this constant discussion, are PARP inhibitors just the sophisticated, expensive cousins of platinum agents? So the JEPAR-OLA study looked at patients who either had a germline pathogenic variant in BRCA, they could also have a somatic BRCA mutation, or they could have a high HRD score. And these patients received neoadjuvant therapy either with paclitaxel and olaparib, or paclitaxel with carboplatinum, followed by an anthracycline and cyclophosphamide, and then surgery. And the bottom line here was that in the patients who were BRCA wild type, okay, so they still had a high HRD score, the platinum was significantly better than the PARP inhibitor. In patients who had either germline or tumour BRCA mutations, then the outcomes were similar between olaparib and the carboplatinum arm. In the advanced breast cancer setting, we have 3 large phase 3 studies, 2 of them that led to FDA and EMA approval of drugs in this setting. And we have a third study called the Brocade 3, which I'll really only touch on very briefly because it's a very interesting study, but it certainly was not a practice-changing study. So if we look at the Olympiad study randomized patients between olaparib and treatment of physician choice, which notably did not include a platinum agent. And here we see a median progression-free survival of nearly 3 months. Some argue that these results were disappointing, but I think we need to keep in mind that this was a very heterogeneous group of patients. Some of these patients had had no previous chemotherapy in the metastatic setting, while others had had several lines of chemotherapy. So this was going to dilute any benefit that we might see if all of these patients had received this in the first-line setting. Remarkably, the overall response rate was doubled, favouring the olaparib arm, and the median onset to response was very similar in both arms, starting to debunk the myth that if we need a rapid response, we need chemotherapy. These are results just published earlier this year, looking at the overall survival. So this is a subgroup analysis. It was not pre-planned in terms of this particular analysis, but I think there's an important message here that we might want to note, and that's that for the patients who received the olaparib as first-line treatment without previous chemotherapy, there did appear to be a survival benefit of nearly 23 months compared to approximately 15 months. So again, this didn't meet the secondary endpoint of overall survival, but I think this is something important to take note of. In the BRCA study, we saw very similar results with an approximate 3-month benefit favouring the talazoparib compared to treatment of physician choice that once again did not include a platinum agent. In terms of secondary endpoint, there was no benefit in overall survival, similar to the Olympiad study. Notably, quite a number of patients actually did cross over and later receive a PARP inhibitor or platinum agents, and I think that would also possibly hide any benefits that we could have possibly seen in overall survival in these patients. The thing that I think is important to note when we're thinking about radiotherapy and this population is that we do know that patients who have a pathogenic variant in BRCA may have a higher presentation of brain metastases. And so in the BRCA study, when they looked at the patients that were included who had non-active CNS brain mets, we saw that the benefit of the talazoparib was present for both those with and without CNS metastases. These are things for us to think about when we think about radiation. There are some studies that have looked at PARP inhibitors as well as immunotherapy. There's the Topacio study that looked at niraparib and pembrolizumab. And what we can see here are response rates that were not really that much higher than what we saw with a single-agent PARP inhibitor. And in the Mediola study, we also see the olaparib along with durvalumab. And once again, the results here did not show a response rate much higher than what we saw in the phase 3 studies with a PARP inhibitor alone. I think these results were disappointing. There was a whole theory that possibly the PARP inhibitors were going to help create an environment where the immunotherapy was going to be more effective. I will just mention back the Brocade study. The Brocade study was a phase 3 study that looked at Taxol, carboplatinum, with or without veliparib. And veliparib, one might argue whether it's really a classic PARP inhibitor. It probably isn't. The results were interesting. The study met its primary endpoint, but it hasn't really entered clinical practice. So you will see in Sophia's lecture some discussion about veliparib and radiotherapy, but veliparib is actually not FDA or Mayo approved for use in breast cancer, but I think it gives us thought-provoking data. We need to remember that olaparib or talazoparib are not just for use in BRCA. This was an important study by Nadine Tung's group looking at an expanded olaparib indication. The patients here could have a germline pathogenic variant in CHEK2, ATM, PALB2, as well as BARD1 and RAD50. What we can remember from one of the earlier slides is that these are all important in the DNA repair pathway. So there was a strong biological rationale for this study. The patients could not have a germline BRCA1 or 2 mutation in the study. However, there was a second cohort which had somatic mutations, and there BRCA1 and BRCA2 somatic mutations could be included, as well as somatic mutations on several of these other important genes in the DNA repair pathway. What we can see here was a really dramatic response for those who had a germline PALB2 mutation. So these results are really very impressive, and I have to say that we're not likely to see a lot of other studies looking at this. There are not a lot of patients with germline PALB2 mutations. For any of you that see a lot of patients, we will probably all have 1 or 2 patients alone with a PALB2 mutation. However, these results are significant, and it does raise questions. What would we do in the early breast cancer setting? Would we consider giving a patient with a germline PALB2 mutation adjuvant olaparib if they're very high risk? Well, we'll never have prospective clinical data on this. So this is something as well for us to think about. The other group that benefited in this study was the cohort with the somatic BRCA1 and BRCA2 mutations. There are many ongoing future studies. One of the ongoing studies that is recruiting at the moment, and will probably finish recruitment in September, is the Olympia-N study. And this is a study looking at olaparib, also in combination with durvalumab in the neoadjuvant setting. The patients will receive this in the neoadjuvant setting, and depending on their response and decision by the treating physician, they can then, after their surgery, either continue just with the olaparib or go on to receive standard chemotherapy if they have not had a good response to treatment. There are also multiple studies evaluating the combinations of multimodality therapies, including radiotherapy, which will be discussed by my colleague shortly. There are also already bioequivalent studies looking at generic olaparib compared to Lynparza. One of the good things about this is that it means that if people want to do other studies, sometimes it can become a little bit more affordable to perform further studies. And there are patients who have BRCA1 promoter hypermethylation, as well as patients with homologous recombination deficiency, where lots of studies are ongoing, and the JEPA-OLA study actually looked at that as well. In terms of guidelines, so in terms of early breast cancer guidelines, there will be an update for the ESMO early breast cancer guidelines in the coming months. At the moment, we have the advanced breast cancer guidelines. So in patients who have triple negative breast cancer, PARP inhibitors should be considered for those with a germline pathogenic variant in BRCA. If they're PD-L1 positive, the inclination of most of the co-authors was that we should start off with immunotherapy and chemotherapy, and if they don't have PD-L1 positive disease, they should start off with a PARP inhibitor. And amongst patients who have hormone positive HER2 negative metastatic breast cancer, the concept is to probably start with a CDK4/6 inhibitor and endocrine therapy, and use the PARP inhibitor a little later on in the patient journey. So in summary, germline testing is really important, and it has therapeutic implications. It's no longer just about risk management and cascade testing for family members, and it's important early and advanced breast cancer, and it's actually a big problem in many countries where there are still bottlenecks to having genetic testing performed. Olaparib improves overall survival in patients with a germline pathogenic variant in high-risk HER2 negative early breast cancer. And both olaparib and talazoparib are the preferred treatments in patients with a germline pathogenic variant in the metastatic setting, and we would consider olaparib for those with a germline PALB2 mutation or a somatic BRCA1 and 2 mutation in the advanced breast cancer setting. So we need to ensure timely and accessible genetic testing. so that patients can actually access the care for a PARP inhibitor quickly enough. So sometimes that's very challenging. If you have a patient with newly diagnosed metastatic breast cancer and a high suspicion of a germline BRCA mutation, or even without a high suspicion, we need to be able to get this testing done quickly. And also for patients in early breast cancer, we need this done probably on not such a quick schedule, but quickly enough to know what to do post-surgery. And we have lots of challenges in deciding how to sequence and not sequence high-risk, hormone-positive, early breast cancer that's BRCA positive. Are we going to give them olaparib? Are we going to give them abemaciclib? Are we going to sequence those treatments? And I've already mentioned the sequencing questions in the advanced setting. And we need more data, and not just about radiotherapy and PARP inhibitors, but as someone with an interest with breast cancer in young women, we actually don't have adequate data about fertility for these patients. So I thank you for your attention.